Welcome to COIQ, a first-of-its-kind video program about health innovators, early adopters, and influencers, and their stories about riding the roller coaster of healthcare innovation. I'm your host, Dr. Roxy, founder of Legacy DNA Marketing Group, and it's time to raise our COIQ. Welcome back, COIQ listeners. On today's show, I have Sarah Sossong with me, and she's been noted by Fierce Health as one of the most influential women shaping healthcare IT. Welcome to the show, Sarah.
Thanks so much. Glad to be here.
So for those of our listeners who might not know who you are just yet, take a few minutes, just tell them a little bit about your background and what you do.
Excellent. So right now I am now working for venture capital firm Flare Capital Partners based in Boston, Massachusetts. In my role here, I am helping invest in in early stage startups, health tech-enabled services. We have 17 companies in our first portfolio. We are about to start investing out of our second fund, which will be about $250 million. So I am on the lookout always for things that are new, innovative, and digital health, great entrepreneurs, great companies that are really transforming the business of healthcare. But I got into this by working on the front lines of healthcare systems across the U.S. And so I'll share a little bit about that as well. So began my work at the U.S. Navy back in 2003 after grad school. So I was a Lieutenant JG overseeing primary care operations. Then I was at Kaiser for 8 years and worked on a lot of different technology compliance projects, one of them being Kaiser's first large-scale telemedicine program. And then Boston, for the last 6 years, I was the co-founder and helped launch the first part of Mass General's digital health program. So we launched video visits, second opinions. So that was from 2011 until just last summer. So I come from a place of piloting things and seeing what sticks to the wall and then executing and scaling it at a large scale.
Yeah, you've been involved in some pretty pioneering projects, and from what I know about your background, all the way from concept to full scale implementation. So I think we're going to have a really exciting dialogue today. So
Wonderful,
tell me,
excited. Yeah, very fortunate.
Yeah, so tell me how you got into telehealth.
So completely fortuitous. So I don't think it was, certainly not a direct connection, but when I was in the Navy, one of the things I was excited about was the fact that I'd barely turned 24, and they put me in charge of overseeing the primary care clinics of 13 clinics across San Diego. And one of the projects that I was assigned to was implementing video conferencing systems all across these clinics. So there just happened to be $500,000 of Polycom video conferencing software and all of the equipment sitting on my floor. So one of the things I did there was implement that. One of the clinics was in a desert 100 miles east of San Diego. One of them was San Clemente Island, 30 miles off the coast of San Diego. But that wasn't the direct connection. I really found that I liked doing projects more than the day-to-day operations when I was in the Navy. So looked for consulting style jobs and moved to Northern California and worked for Kaiser for 8 years. And I worked in 3 different groups within Kaiser. I worked for the health plan hospital, and then I worked for the medical group. And then in the end, I worked for the national group as well, which was called the Federation. But when I was working for the medical group, we had a VP who came to us and said, we have this area in Northern California where we have this severe problem of derm wait times. We can't get patients in for 9 months to a year for these derm conditions. And obviously, that's too long to wait. And he didn't give us the solution. He just said, can you solve the problem of this derm access? And so we approached this problem, and obviously telemedicine was one of the things that we came to as an idea. But the only telemedicine being done back in 2008 was at UC Davis, and they were doing all video-based telemedicine. And for us, the problem was the amount of dermatologist time available to see these patients. And so the 2 fabulous dermatologists I worked with, Elizabeth Cass and Eileen Crowley, said, we can see in 5 seconds and a photo what this derm condition is. Mm-hmm. So I think in many ways we decided to test, pilot, and innovate around an idea of taking photos of derm conditions, which there were a couple other things, and now it's a very common thing. But we use Kaiser's Garfield Innovation Center, and we basically mocked up how would it be that a PCP who is seeing a patient in clinic could take a photo, send it to a remote dermatologist, have that remote dermatologist view it, give some feedback, send a prescription or a referral as needed. And how could all of that happen in the course of a patient visit that was just a 15-minute patient visit in the office? And so over the course of piloting, we figured out how to actually do that. So we were able to have patients who are coming in, it could be for 5 different things, but if a derm condition was one of them, we would take the photo. We hired a full-time dermatologist who was based in San Francisco, who was doing the readings, and we had a rotating schedule of dermatologists. And basically through the course of, getting buy-in from the clinics, getting buy-in from the PCPs, getting buy-in from the patients, we were able to get to the point where we were doing 3,000 of these, what we call derm e-consults a month. And through the course of seeing how much this impacted derm access, so patient satisfaction was virtually 100%. I think the PCPs, it was some extra work for them, but we also made it very easy for them in a lot of ways. And so all stakeholders ended up being a lot happier. And I think we were actually surprised at the PCP satisfaction. We found that PCPs were often referring things to derm, and they, through the course of getting derm feedback, so maybe they see psoriasis 3 times. And once they've seen it 3 times, then they know what to look for, and then they know how to treat it. So they felt very empowered. I think there was also a situation where a PCP said to a patient, I know exactly what this is, but the patient didn't believe her PCP and wanted a referral to derm. So we were able to take a photo, send it to the derm. The derm confirmed what the PCP thought, and in that case, it really strengthened that patient-PCP relationship. So through the course of seeing how this was impacting patient satisfaction, PCP satisfaction, the total cost of care, quality, I got really excited about that. Long way of saying, got really excited about telemedicine as just an overall area where we could be making really big impacts through a lot of different types of interventions. Basically telemedicine is providing medical care from a distance via technology, and that covers a lot.
Yeah. So what's fascinating to me is that you were one of the pioneers in this. So, telemedicine, telehealth is so much more common today than when it was when you first got started. So I'm really curious, it was really radical when you were doing it. So what I'm really curious about is, what were the challenges, unique challenges for you think, because you were so early?
That's a great question. I think people are concerned about privacy from an organizational level. I think that wasn't one of the things that was a challenge for us. That was never something patients or PCPs asked about. I think it's something that when I talk to health systems, they ask about. But I think one of them was just really even how to describe it. How do you say you're doing a visit over telemedicine? Do you say you're doing a video visit? You're taking a photo, like just how you describe the interaction. And I'll give you a couple examples of this. So we were doing a focus group to figure out what to call this. And we had a group of, it was tended to be more elderly people. It was a patient and family advisory council group. And we were going around saying, what do you think of when you think of telemedicine? What do you think of when you think of telehealth? And this one woman who was probably in her late 70s, and she was a nun, so she was in her full garb, said, we've been talking about this. Are you saying telemarketing? And she literally thought we'd been talking about telemarketing the whole time. So I realized that telemedicine was clearly not a term that resonated, and so we ended up going to other things instead. So I think the other thing is but just how to describe it, because part of the thing is you need to get buy-in from patients, and we also really found that when the physician says to the patient, hey, we have this program I'm supposed to use, and I'll get some derm feedback, but I don't know, I'll do a photo, do you want to do it or not? That doesn't sound very convincing.
Right.
And that was what was happening quite a bit. But if you have a PCP who says, we have this fabulous new program. I could give you a referral to Durham for an in-person visit, but you won't be able to get in for 6 months. But if you don't mind, I'll have my MA come in right now, take a photo. I'll send it to the dermatologist who's waiting for your consult. Go to the waiting room, wait for 15 minutes. We'll have a response back. I'll call you back into the office. I'll share the diagnosis, the prescription that the dermatologist recommends. And you can go pick it up before you leave today. It's just much more empowering. So there was a lot to getting the physician buy-in in order to really pitch the program. So kind of back to, we needed to know how to describe it, and what the benefits were to even get the patient to say yes in the first place.
And that's something that's really common. That whole positioning in kind of what category do we fit into is really challenging for, breakthrough or radical innovations. Because, if you're pursuing the early adopters, you want to be able to communicate that it's unlike anything they've seen before. But at the same time, how do you describe and get someone to understand something that they haven't seen before? So without, watering down the revolutionary aspect of it. So it's definitely something that I see that's really common.
Yeah. And I have some other thoughts on that too, depending on how far you want to go on that. I think another, so 4 other thoughts. One is just, are you solving a problem or are you looking for a use of technology? This was more when I came from, I consider KP the early days, because that was back in 2008. So when I started at Mass General in 2011, 2012, there were a lot of people that actually knew what telemedicine was, at least within the physician community, and were excited to use it. But one of the problems I found is that we were often trying to find a use for the technology rather than solve a problem. So I think so the 4 things I'll talk about, I don't think are any different from today, but they were things that I found were really the big barriers from the beginning. So one was, are you solving a problem or are you looking for a use of the technology? And the places where we were solving a problem, it obviously worked well, and not the other way around. So I think we all have things that you're smiling and nodding. So we all have those examples. I think the other thing, which again is I think quite common still to this day, is physicians aren't going to do something if they can't get paid for it. They may do it 1 or 2 times, but they're not going to do it as part of their everyday clinical workflow. And so how to pilot something that was innovative, that payers weren't paying for, and get physicians to use it at scale was really a challenge. And I think this is something that continues to be a barrier. We're making a lot of progress, but at Mass General, we ended up creating a fund that was almost, we created a mechanism to pay ourselves. So the physicians, when they would do telemedicine visits, whether it was video, second opinions, or other things, we came up with a way of basically deciding how much their time was worth and how much that visit would get paid to them. That was essentially an equivalent of what a fee-for-service in-person visit would be for them. So that was, we were able to, at least in the early days, solve the problem of physician payment. But I think as we got a lot of traction, we got to the point where, people could do this 100% of their practice. We actually found that psychiatry, all of a sudden we were afraid that we weren't going to have adoption. Psychiatry blew our budget out of the water, and basically we had to go back and tell the department to stop because they were doing too many visits. And it was a good problem to have, but I think it just highlights the fact that, I think then the problem we had was, how do you say, well, use this sometimes, but don't use it all the time? And I think it doesn't work if it's not something you can think of for every patient. And that's really stuck with me with everything else I've worked on. I think same on the regulation, it's just really challenging. Can I do this visit with a patient in another state, or can I do a first visit? Can I prescribe medications? There's so many questions around the regulatory environment that I think oftentimes physicians tend to not do it at all because they're concerned, and that's probably safe from their perspective. Their licenses, they're key to being able to hang out a shingle and provide services. So part of what I liked in my role at both Kaiser and Mass General is being able to help provide a framework and share. I'm not a lawyer, but I was able to share, here's the law and here's what we are allowed to do. And I think that getting them comfortable with that was huge. And then the 4th challenge would say, I think it's probably still the biggest one and the most important is, you have to have leadership buy-in and vocal endorsement at the highest levels. And I found that through the course of various work I was doing, I was hearing from our leadership that this was of utmost importance. Telemedicine and digital was the future. It was something that we had to provide for our patients, our physicians had to do. And I would go, so that was the message I preached. That's what I evangelize. It's what I believe, and that's what I convinced people. It's what I convinced my team of, our leadership of, and others. The challenge I found, which was really surprising to me, is I would go and I would talk to the chiefs of the departments. And, they were bought in, they were excited, but they would say to me, Sarah, I absolutely agree, and I want to do this too. But at the end of the day, our CEO has a list of 10 goals for me for this year, and digital health and telehealth aren't anywhere on there. Mm-hmm. And we've got so much to do. We're being told to cut budgets. We're managing staff. If it's not on the top priority list, then it's not something I can really tell my team to focus on. So I think part of it was figuring out how to work with leadership so that this was really, it wasn't coming from Sarah, because that wasn't the powerful message. It was coming from the leadership. So I think there are a number of organizations that have really highlighted from the very top how important digital is. And I think Cleveland Clinic has access anywhere, anytime as a theme. Mayo Clinic has the goal to touch 200 million lives by 2020. And those are things that they're very much enabling through digital. And if you go to their patient websites, access to a physician via video and second opinions is right there on the front page. So really a lot of the work I did was trying to get this to be something that leadership is saying, in alignment there.
So it's really fascinating, because those four things actually hit not all the questions, but every one of those are on my list as questions. So I love it. So I kind of want to start with the first one. You kind of talked about, starting with a problem versus starting with technology and trying to find a use case. Talk about, how did you overcome that when, obviously when you start off with a problem, you're going to have a lot more success. So, when the organization is really starting off with more of technology, what did you have to do to really change that? Was it to, kind of reverse engineer and find the problem? Was it, getting patients or providers involved to kind of help educate and identify what was the most important problem to be solved? Was it one of those leadership, challenges? Just kind of help our listeners understand how you overcame that, because I think that that's something that folks run into really often. They get really, really excited about the technology and then kind of look at trying to solve the problem later.
Yep. No, that's a great question. And for the listeners' benefit, I got none of these questions in advance. Apologies if I'm pausing and thinking for a couple minutes on this.
No. Thinking's good.
Yeah. So, I think the way it first hit me was, when I was at Kaiser, I was doing a very structured program that was solving a very specific problem that was handed to me. Yep. When I came to Mass General, I was instead handed the responsibility for building a program and getting traction, and there was no definition around what we should focus on, what our products were, who I would work with. And so in my first couple of years at MGH, I spent a lot of time going around trying to find people that were excited about working with technology, using technology. And so I think very naturally, I ended up getting a lot of people that were excited about using the technology and using telemedicine, but didn't have a problem to solve. And so I think it was, I was at first excited to meet those people, but then very quickly realized that there were a lot of those people and more people than I could manage. And so it actually turned into one of those things where in order to manage the volume of inbound interest, I really had to say to my leadership and, within the small team we had, of these, I'm a team of one, or, there were a couple of partial FTEs that helping out in the early couple of years. How do we prioritize among these 10 things sitting on our desk? And I think one of the things we started to say was, let's come up with some sort of framework for how we say yes to some things and no to other things. And that's, I think, was really driven, and gets at your question of how we got people to think about this as solving a problem, but it's a little bit more nuanced and specific. So we came up with this framework that we called PERC. So prioritization, impact, readiness, and complexity. And so we started to look at these initiatives, and when we said no to things, so I think part of the reason we had to do this also is because I'd say no to something, there's no problem that they're solving. There's no market that's willing to pay for this. And the person would email their chief, who would email their VP, and then the VP would email my bosses, and my bosses would say, Sarah, I heard you said no to this. You need to do this. And I'd say, but this is not at all aligned with what we're trying to do. So I think establishing this framework was also a way of getting my direct bosses and also the hospital leadership on board with this is how we were thinking about these programs, so that, the next time that thing came through, the VP that, was looking at it said, yeah, no, that actually, it's not a priority of the organization, or that's a really great program, but you're probably going to have one consult a year, and that's just not high enough. So we thought about things in terms of prioritization with organizational strategy. And the two things we were thinking about were population health management. How is it helping manage costs, increase value, impact quality? Or was it something that was helping sort of expand our network within the Mass General system? So that was priority. The impact really was around how big was this. We had some programs that when they worked would save a life, but if they were only happening once or twice a year, was it worth putting together these huge contracts and spending 100 hours of staff time to put all this in place? Or is it worth spending that time on something where we have one consult a day, or 100 consults a week, and so it really helped us shift towards things that were higher volume, and that's really what gave us the early learnings we needed to then be able to go and do those smaller volume programs. Complexity was the third one. If you wanted to do a program that involved video and imaging, and it was across state lines, and you were going to be doing new patients, and you're going to have to bill Medicare, just the more complex it became, the more difficult it was for us to put all the pieces together. Sure. So that was one of the things we thought about, and is I think good for people to think about with their programs. And the last was readiness. If you had a department who was ready to go, someone they had assigned who was an admin or some sort of project manager to help, if they had physicians, all of that readiness, this factor. If they had a client who was willing to pay, all really helped. When we had a single physician or a single administrator who had an idea for something but had not yet checked the market and engaged interest, it leaves things in a very different space. So it was ultimately around getting back to, we were trying to solve a problem. We were trying to solve problems that would be able to really make an impact quickly in a way that would be good for the organization, good for the customer, and really move the needle.
Mm-hmm. Yeah, that's great. So let's kind of move on to the number 2 that you talked about, physician payments. So obviously that's going to be really critical for motivating them and getting them inspired and engaged. Help me understand, and our listeners understand a little bit more of, what was this creative fund that you came up with?
Mm-hmm. Yeah, so I can talk about that. And in some ways, number 2 and 3 on the reimbursement and regulatory, are also part of this bigger theme of just physician adoption in general. Yeah. I think a big one. So maybe I'll talk about it in terms of physician adoption. Perfect. And I can talk about the fund piece of it as well. But so I think solving the physician adoption problem is something else big. I think we look at the typical hype cycle chart all the time, and typically we're seeing that it's a few providers as opposed to many. And I think this is something that became obvious to us really early. So I mentioned the fact that behavioral health and psychiatry blew our budget out of the water, and I'll describe the budget. So basically what we did is we came up with a pot of money, and when physicians bill for in-person visits, they assign a CPT code, they write the visit note, they submit that to the insurance reviews, basically sends it back with the payment based on that patient's eligibility and everything else. So far simplifying this, but what we did is we set up a mechanism where physician, we spent a lot of time thinking about what was the right level of payment, but basically came up with something that was a dummy CPT kit system. So instead of putting the actual code, they would put VIR or VID something. So anyway, they came up with a code, and they would click submit in the same way that they did their regular visits. Yep. And instead of that code basically was a signal to our billing system to not send the bill out to the payers, and instead to send it to this internal group that was looking at these visits. and it would initiate a payment out of this internal fund we had. So I think, it ended up, once we had buy-in from leadership that they were willing to give us the funds, they directed the finance folks to help us put this in place. It then worked fairly easily. And I think that the big thing is, even if there are more efficient systems, doing what the physicians do every day all the time is always a better way to do it. So, the fact that we weren't trying to reinvent the wheel in terms of the billing, we were just using the same mechanism for the different companies. And so that ended up being a good mechanism. We actually had talked with Geisinger back in 2011, I think, and heard that they were doing something like this. I don't know to what extent they were, but it was something that I think we were one of the early pioneers of, and a number of other systems did it in the years after us. I think most states at this point are reimbursing. So I think we do at MGH, while I'm not there anymore, that fund still does exist, and it exists to pay for the visits that payers do not cover, since payers are covering quite a bit now. But to the point of how do you solve this adoption problem, one of the things we also found was, so when our budget was getting blown out of the water, we were excited and wanted to think about, so maybe this means we need to advocate for more of this money. We said, well, let's also dig down into who are the actual physicians that are doing this activity, and maybe that will tell us something about utilization and value and where's the right place to use this. And out of a department of several hundred clinicians, we actually found that 90% of the money that had been spent was being done by 6 physicians. So out of hundreds, there were 6 people that were driving 90% of the utilization. So it was, I think it also highlighted us just to this bell curve. It was something that 6 people were doing, not the whole department. And so it was great that those 6 were doing it, but how do we get the broad adoption? And so that was something that really became our focus in the years ahead, was how to, why was it only these 6? Why wasn't it the others? And I thought it was unique to MGH. As I've talked to other health systems, this is not unique to us whatsoever. And as we rolled out to new departments, we found likewise, it was the same in neurology, it was the same in cardiology, it was the same in ortho. And I think one example that I use a lot that continues to puzzle me and would love, I really should reconnect with these 2 women to delve into this more. But we had a woman who is a female cardiologist of a certain age, of a certain ethnicity, saw a particular type of patient. There were 10 different descriptive details around her. And she had so many visits that she was doing over video that she had enough that she could do an entire clinic. So she was doing 10 to 15 patients a week at home, not in the office. And so she, again, kind of where cardiology was concerned, she was blowing it out of the water.
Yeah.
And she had a female counterpart who literally sat right next door to her. Those 10 descriptors also fit her colleague to an absolute T. They saw the exact same patient. And that woman had tried video visits, didn't like it, and didn't use it at all. So I think when you try to say, is this something around, is it a certain age? Is it a gender? What is it, because it's the right clinical condition? I don't think there's an easy way to say, oh, it's just an age factor. It's just the type of patient. So there's some trick to this adoption that we have not yet solved. So I give that more as an example of that. I think don't be quick to jump to conclusions around
so one of the things
why
that
people are adopting or not.
Yeah. So one of the things that I talk to clients about regarding that is this early adoption strategy and kind of the bell curve that you're talking about and how that aligns with the diffusion of innovation model. And so one of the things that I see happen all the time is, they've got a small subset of the population that are innovators and early adopters. And if we can identify who those are in the population, then we're going to have a much greater adoption success than we would if we were going after the mainstream market. What I find happens most often is the health innovators that we work with, they just kind of see the market as kind of like a whole segment, like you're talking about, and they're banging on the door and trying to convince the mainstream market to buy in, and they're just so much more risk averse than the early adopters that or trying to get laggards to buy into it. And so it becomes so discouraging for them. And sometimes they run out of money before they actually get to market because they're, trying to convert, the wrong segment of the population. So I think having that early adoption lens is really, really important.
Yeah. And actually one thing to that point, I think as we saw that there were these few early adopters, some of the goals that we created ourselves were around having broad adoption across the entire department and like having the entire department do it. And I think there are arguments for both sides, but where I come down is on the side of this isn't something that needs to be for everyone. I'm of the opinion that there could be some people that are really good for in-person and that's what they love. And there are some people that maybe want to mix and some people that almost, I think having a mix is good, but some people who maybe want to do mostly virtual. And I think the idea that this is something you should have everyone doing at the same levels is, just doesn't really match human behavior, at least with how we practice medicine right now. So, and I think that was just highlighted with my Kaiser experience. One of the early dermatologists that we used, he was just not a good people person. He did not interface well with the PCPs. The way he interacted, it did not go well. When people interacted with him, they did not want to do this ever again. And there were other people that, were just lovely. They, were very careful about developing the relationships and, being really a consultant to the PCP and not, it was a lot around communication and style. And I think the same thing was true at MGH. So there are people for whatever reason, maybe it's tech savvy, style, communication, everything else, but I'm of the opinion that, maybe it will be not the entire bell curve ultimately. Maybe it'll be more beyond that just early adopters, but that's a good place to start. And I don't think any reason to try to force things beyond that sooner than we need to.
I like to use the cell phone because I think it's so pervasive that it's really easy for us to kind of use that as an analogy. You had groups of people when the iPhone first came out that were paying $700. And at that time, that was just absurd amount of money. And they were standing in line overnight, right, for days to get to be the first person to have this iPhone. And today, you still have folks that have a flip phone and they are not going to let that flip phone go until they don't make it anymore and someone takes it from them.
Yep. Yeah, very true. Very true. And that's been much more like letting the market drive. I think, healthcare is one of those things where, to some degree, the hospitals aren't really following. It's healthcare is so different than the rest of the tech market in that, patients often want their physician to tell them what to do. So unlike the cell phone, where it's something, no one's recommending anything. I just go and I get what I want.
Right.
But I think very true that there's that same adoption curve, but
Sure.
Healthcare is even more complicated because then the physicians want the buy-in of their broader department, the organization, the patients aren't going to want to do it until the physician says it. And I actually have an example of that. We had a snowstorm a few years ago in Boston, and we thought, what a great opportunity to convert a lot of in-person visits to virtual to, get people.
Oh, yeah, right.
And so some folks on my staff, were given a list of patients who had visits the next day, and we're calling up the patients, and, I don't know the exact script, but they were saying something along the lines of, there's supposed to be a snowstorm. I'm sure, these are one of those days in Boston where you're actually the roads are legally closed and you're not allowed to be on the road. So it wasn't a matter of I'm going to face the storm or not. And, would you like to have a video visit with your doctor instead? And so I got a report back from a couple of people on my team that we'd had no uptake, that, out of 30 patients asked, none had said yes. And I said, can I get on the phone and try some of these? And I very quickly realized that if I said, and actually there was I think a Boston Globe write-up around this. So I was working with Jason Watsky, who's a cardiologist at Mass General, and I said, hi, this is Sarah Sossong calling from Mass General, about the storm tomorrow. Dr. Watsky asked me to give you a call, and he would like you to have a video visit with him tomorrow instead of sit in person. There's no reason to miss it. It'll just be just like your face-to-face. But, Dr. Watsky wanted to make sure that was okay with you. And that knowing that it was coming from him directly as opposed to feeling like a robocall, I had 100% of patients say yes. And so I circled back with the rest of the team and modified how the question was being asked. And, just little things like that you don't know unless you're on the front lines. actually talking. So, I mean, if it hadn't been for that experience and me getting involved and chatting with patients directly and messaging it differently, it could have been that we came out of the storm saying, wow, even with a storm, patients don't want to do this. But it was actually how we talk to them. And, so knowing it came from their physician made all the difference in them wanting to do it.
I think that's such a powerful insight, that the language and the messaging can make such a huge difference. And like you said, you can walk away thinking that people just don't want this technology, even when they're stuck in their home. And that could be a complete wrong assumption, right? Because there's so many variables at play. That's just such a profound example. Thanks for sharing that with us. So a couple of things that I also want to talk about is a pilot. So, you've done several different pilots. And so for those of our people that are listening in our audience, many of them are either, in a pilot right now, or they're, developing all of the guidelines and negotiating their pilot. So what are some best practices or must-haves that you would recommend that they stay mindful of in the pilot kind of like pilot agreement, pilot development process, in order to make sure that when that pilot is over, that they've got what they need to, kind of implement at more full scale?
Mm-hmm. I'll start with three things, and maybe we'll go beyond. But I think one, being mindful of that prioritization framework. Won't start with don't. Do something that you think is scalable beyond the first, that's bigger than what you're doing right now. So you have to start small. I know there's a big move away from calling things pilots. Even things that are pilots, people are saying, don't call it a pilot, call it a program, because that creates a certain amount of sort of organizational and departmental buy-in to the fact that this isn't something that is
it's not ready yet, right?
It's not ready. It's not ready yet. Like, programs aren't ready yet too. So I feel like I hear everyone talking about these things called programs, and they're actually pilots, but they're calling them programs. So, please, I'll leave that to the audience and their stakeholders, but I agree, they're really pilots. So pilot something that you think is scalable beyond what it is you're doing initially, in a big way. And I think, the traction that we got in video visits at Mass General was one of those things. The problem that came to us, and this was within the first couple of years, was the problem of a psychiatrist, Janet Wozniak, who had patients coming in from all over Boston for treatment for autism, ADHD, and bipolar and other things. But through the course of giving them medication, they were often on treatments that required her to modify the doses and the medication themselves over the course of multiple weeks. So these patients were sometimes coming in twice a week, but coming in weekly, twice a week, so very, very frequently. And, especially around the autistic population where she started, by the time a kid is pulled out of their regular environment, so they're pulled out of their school, they're brought in the car, then they park, they find their way up to the 8th floor of the building, and then they're waiting in the waiting room for an hour. By the time they actually get into the office with the physician, she's not able to see them at their regular self, because they're extremely, like, any of us would be irritated. I'm irritated even thinking about, like, all of that process.
Right.
So I think one of the things she was thinking is, like, she can't possibly assess them, much like not even to think about the convenience or any other piece. So we were really solving the problem. How do we let her see the patient exactly as they are? And we were solving the problem too. It was very inconvenient for the patients to come in, or for the parents to take time off. So we solved this problem of, being able to do a follow-up video visit for patients with autism, but very quickly, we did that knowing that this is something that could be used so broadly and applicably. It's a very, very simple example, but I think just applying that logic to any intervention. If you're going to do something, where will the next thing be? Do you have any sense of that? Maybe it ultimately won't be anything beyond that, but I think if you don't want to start down a path where you think this is going to be the only sort of pilot approach.
Yeah.
So that was number one. Sorry. So things to keep in mind. So the scalability. I think definitely the champions. I think this has been well talked about and documented, but just, as the administrator and as the business and technology champion of this, ultimately I could convince the first couple physicians, but I wasn't going to convince an entire department. So really figuring out who the internal champions were was really a win-win. I think for many of the physicians that I worked with across emergency medicine, cardiology, neurology, psychiatry, there were so many of them. This became something they were really excited about, and this became their thing. And they're now building careers doing research in telemedicine. But, for them, the chance to be the champion was, for me, really important because it gave me a person through whom I could evangelize to the rest of the department. And for them, it also gave them an opportunity to really differentiate themselves and be internal leaders, both within the department, within the organization, nationally in some cases. But finding those champions and figuring out what actually motivates them. And then I think the third one is really figure out what your resourcing strategy is. It takes a lot of work. I spent so much time thinking about, what was the right way to actually implement a pilot? Do you implement a pilot entirely with staff of the telemedicine group or whatever innovation group you're in? Or is it entirely on the department, or is it a combination of the two? And I ended up creating this graph that showed basically how there was no way. I think our leadership really wanted this to be 100% on the department to implement from day one. And I really ended up saying, there's no way they can do that because they don't know how. Until we teach them, they don't know how to do a test call to test a patient's video. They don't know how to, double check why the technology is not working. They don't know how to onboard a new physician. So there's just any number of things that we could very quickly teach them, but they couldn't do it from day one. So I had this, I don't know if you did, but kind of this graph that, where our involvement kind of went from up to down, and their involvement, it wasn't at zero, but it was pretty low, and it went up over time. And at the end, when we were at full scale, well, we never ended up being at whatever point where it's at full scale implementation, execution within the ops. There's always going to be a time where you need to call someone to ask for technical support. There's always going to be some sort of baseline infrastructure supporting these programs. That probably will move to IT. It'll move to existing places, but until it really becomes mainstream, it will still live in the telemedicine digital health innovation groups. But I think really, convincing your leadership that your departments can't do this on their own is really important if you want to be successful. Because then you're not going to have, again, and kind of back to, you won't have adoption, and then they're going to say it's a failure, but it's not actually a failure. It's just the fact that you didn't sort of implement and resource it the right way from the get-go.
Yeah. I love the graph because it's so clear as to what you're talking about and how you have that exchange. The real one is much prettier. Yeah, I'm sure. So I'm curious, you've got all this experience working in these large behemoth organizations and trying to innovate internally. And, most recently you're in this role, working for an investment firm that are working with health innovators. That I'm assuming very often are early stage startups. And so what do you think the differences are between trying to innovate within a large existing organization and trying to innovate as a startup? What do you think
very differently?
What do you think that's kind of common, and what do you see like, gosh, this is really different?
That's a big question. So what's different? I guess, I've learned a lot about venture and investing and entrepreneurship, and there are many stages of company creation. At the earliest sort of seed stages and A stages where a company's gotten just a little bit of money but is still really testing, I'd say perhaps what's both common and one thing that's common is the fact that they're trying to figure it out. Companies that we're looking at are trying to figure out, so maybe they've developed some technology, they have some idea for how something's going to work with a particular customer base, but it's through the course of actually trying to get customer contracts, having the customer use the product, that they iterate and evolve. And I think the successful companies iterate and evolve, the unsuccessful companies don't iterate and go away. But it's been surprising for me to see that there are companies that aren't getting traction and don't use that as a sort of an indicator to move into different areas. And so I think very similarly, the health system, needs solutions that are further along, but in many ways, even though they're using products that are further along, they too internally are trying to figure out the right spot for this, for their particular product. What's the right payment mechanism for the right users? What's the right volume? What's the right strategy? I think on the differences, I think by the time you get into an organization, though, you do need to have a certain level of polish and buy-in and other customers. I know at Mass General, we did do some things where we were the first, but as we looked at technology broadly, we were very often looking to see, okay, have you used this with other providers and health systems? What was their experience? Have you actually worked with an academic medical center? Because even those are very different.
Sure.
And so we were really looking for that traction. With startups, you don't need that. And we see people, actually, we talked to someone earlier today who has an idea for something. It's literally an idea, nothing even on paper.
Yeah.
And that's okay. And so the fact that it can be much earlier and conceptual, is I think one of the differences for me in figuring out how to work and think about the space. So yeah, that would be a good full-on podcast.
Right.
Similar between, but no, there many, but I think those are ones that come to mind right now.
Yeah. So and I completely agree. I think that we could talk, we could probably have 3 episodes because you've been involved in so many different angles. I think there's so much to talk about, but we'll have to do that on different episodes. But I do have just a couple more questions for you, kind of just switching gears and putting on maybe more like the Flair Capital hat in your current role. A lot of our audience is these health innovators that are pitching to people like you. And so, what advice do you have for them that are in the trenches right now? I hear a lot in the industry about everybody talking about innovation, but is anybody really investing in innovation? And if they're investing, is anybody really adopting innovation? So just kind of talk about that a little bit from the investment firm standpoint. What do you have?
Well, I do think that in all seriousness, I think that would be a very good subsequent topic, venture and, investment for entrepreneurs. She gave a talk at the American Telemedicine Conference in New Orleans last month about this. And so I put some thoughts together and so a lot to say on it. I think one is digital health investment is at an all-time high. 2018 saw the most money ever put into digital health. So I think that says there's a lot of interest from the market. I think at the same time, the money is becoming more and more concentrated in later rounds. And so people are looking for more mature solutions. So how do you approach, I guess the short answer, since we're coming up to the end, is you've got to have, even at the seed stage, an idea for what your product is, what's the business model, what's the competitive marketplace, oftentimes in order to be successful, you need to start small, but what is the vision for the big business that you're building? That's good to say up front, because if an investor doesn't see that this is going to be a return on the investment, ultimately we have people investing money in our funds that we are then investing in companies. And we're very much about improving patient care and improving the healthcare landscape. But if we go back to our investors and don't make money at the end of the day, we're not going to get that next round of investment, and we won't. So margin over mission is one of those things.
Right.
A lot of the time. So I think you really have to be very clear on what the problem you're solving is and what that product is. And I have just been surprised at how many entrepreneurs haven't really thought through all those points. It's fine if you come in saying, I haven't thought this all through, and here's what I'm thinking about. But if you come in saying, here's my product, and you haven't thought through those points, that's a different story. And there are so many accelerators in different cities now. So Massachusetts has the Mass Challenge Health Tech Program. California has TechStars. There are programs in virtually every city. Those can be really, really useful in helping entrepreneurs refine that messaging, thinking through that, actually partnering them with clients. But I think really having your pitch down would be the number one thing.
Yeah, that's great. So what project are you working on today?
So a lot of different projects. There's never a single project. This world appeals well to my desire to be doing a lot of things in different spaces. I'll just say briefly, we have our limited partners who invest in us, and so I'm working with them to make sure I understand their strategy and supporting the partners working with our portfolio companies. And that really appeals to my operator side, so doing day-to-day operations. We have internal initiatives. I'm constantly, and then my day job, and the biggest thing I've been hired to do is to scout for startups and entrepreneurs and look for the next big idea. And the thing I'm most excited, well, I'll share all four. I have a couple areas I'm interested in. One is asynchronous telemedicine. So I think synchronous telemedicine is huge, but it's now being paid for. And so there are more and more solutions in that space. Asynchronous is not yet being paid for, so I think there's a real opportunity to get the next big thing. I think tangentially behavioral health is such a huge problem. So yeah, three things. Asynchronous telehealth, behavioral health, and then what's called femtech. So on the behavioral health side, there's just such a huge problem. Again, video won't solve anything. We don't have enough psychiatrists or therapists. And then, women's health, I'm just seeing it's going to be a $50 billion industry by 2025. So women are the decision makers for the families. Mm-hmm. We as women go through many cycles of life between, fertility, pregnancy, postpartum, menopause, everything in between. And there's a lot of growing investment and interest in what's called the STEM tech market. So I think that's probably what I'm spending the most time thinking about right now. So any ideas? Love to chat with entrepreneurs anytime. So.
Yeah. So how can people, so first of all, let me say thanks so much for sharing your wisdom with our audience today and with me. I really appreciate you taking the time today. And for those of our listeners who have some questions for you or have something that they want to pitch you, how do they get a hold of you? What's the best way?
Absolutely. No, thank you for anyone who got to the end of this podcast. Thank you for listening. And yeah, happy to share my email. So my Twitter handle is @Sossong Sarah. Email is sarah@flarecapital.com. And I think that's also on my LinkedIn. So LinkedIn is just Sarah Sossong, and you can also ping me on LinkedIn, but probably email is the most direct. But any of those three forms. And yeah, happy to have you share that when you put this out there.
Awesome. Thank you so much, Sarah.
All right. Thank you so much.
What's the difference between launching and commercializing a healthcare innovation? Many people will launch a new product. Few will commercialize it. To learn the difference between launch and commercialization and to watch past episodes of the show, head to our video show page at drroxy.com. Thanks so much for watching and listening to the show. You can subscribe to the latest episodes on your favorite podcast app, like Apple Podcasts and Spotify, or subscribe to the video episodes on our YouTube channel. No matter the platform, just search COIQ with Dr. Roxy. Until next time, let's raise our COIQ.